Hi, I'm Larry Micarendo, and welcome to this edition of Excelsior Forum. And with us today, Dr. Mohammad Athar. He works with I would say, a great group of surgeons at Complete Orthopedics, which pretty much covers a lot of joints, pains, aches, and everything else, which are some of the things we're going to talk about. One of those things is, it's out now, it's new, I would say it's fairly new, is ankle replacement surgery. For those people that really have a problem with feet, most of the time we don't even think of our feet. They're just taking us wherever they go until they start hurting. And when they hurt, boy, do they hurt. So if you could tell us a little bit about, first of all, just as a refresher course, what is arthritis?
Right. Thanks, Larry. Thanks for that introduction. So arthritis is inflammation of a joint, just to break it down. When a joint becomes inflamed, the cartilage in that joint starts to wear down. And as the cartilage wears down, we find that there's pain, there's swelling, there's loss of motion, and it can be quite debilitating. Many people can't walk on these painful joints. Your muscles will atrophy over time because when something hurts, your muscles don't move it. And as time goes on, we come up with very many treatment options to try and address these symptoms. With arthritis, there's lots of non-operative and operative treatment options. You can treat arthritis with medication, you can treat it with physical therapy and braces, you can try injection options, you can try offloading it and lifestyle changes, but ultimately when all of those non-operative measures fail, that's when we start thinking about surgery.
Yeah, so what basically you're doing with most of those therapies, though, is you're kicking a can down the road, because the bone is not regrowing, it's not getting smooth. And a lot of times we hear this expression, which some people may know about, bone on bone.
Right.
Now, what exactly is that?
Right. The cartilage fills the space between the two bones. Right. Cartilage absorbs all the shock that goes into weight bearing. It provides a smooth surface for the joint to move like a hinge, and it's like a bearing. When that bearing loses its lubrication, when that bearing is no longer smooth, then the joint moves like sandpaper against sandpaper, and that's bone on bone. There's no more smooth motion anymore, and that bone on bone state, and there's lots of inflammation, there's lots of pain, and it's incredibly debilitating to try and walk on a joint where there's no cartilage left.
And also that bone on bone, isn't that like a grinding? You're
That's
going
right.
up against
That's
the
the grinding that you hear.
Oh, God. Now, what exactly is ankle arthritis? Because I've never really heard of this term.
Yeah, it's less common. It's much less common compared to a hip or a knee arthritis. Ankle arthritis happens more commonly as a result of trauma. So about 70 to 80% of cases of ankle arthritis are the result of people that have had previous fractures, people that have had a history of recurrent ligamentous strain or ligamentous sprains where the ligaments have been torn. It's usually the result of that initial impact that damages the cartilage, and over time that cartilage wears down and breaks away, and then eventually you get arthritis. That tends to happen decades later. There are less common states where you have arthritis that happens on its own, that happens to the natural degenerative process, like in the knee and the hip. And some people with things like hemophilia or inflammatory conditions can also get ankle arthritis.
Now, ankle is kind of rough because, like, the way the bones sit with the ankle, right? It's like double-sided, and when you get arthritis in that ankle, I'm figuring you're going to be on crutches, and I guess in very rare cases, if you got it in both ankles, that would, you're not going anywhere.
That's correct. Yeah, it can be quite debilitating. If it's bone-on-bone ankle arthritis, most people are walking with a limp. They're not moving their ankle at all, and it affects your gait. It slows you down. It takes more energy to move, to get around. And when you lose the ability of your ankle, you really understand what it does, right? In any given day, the ankle will see 20 times your body weight at the joint line, and that's a tremendous amount of force to be going through such a small surface area. The cartilage that's in the ankle tends to be denser. It tends to tolerate shear forces better, and so over time, the ankle has been designed to tolerate that. But when you lose it, that means that the pain and the swelling, the stiffness is compounded, and so people will really feel that.
So what kind of surgeries can be done for people that have ankle arthritis?
So if you're talking about the young sort of sports guys with early arthritis, the athlete, sometimes we'll do an arthroscopic surgery where we make 2 small incisions. We put a camera in one hole and an arthroscopic tool in the other incision. And we can clean up any bony spurs and try and get some of the cartilage to grow back. That's really an option for someone with very little arthritis, but is an athlete and wants to get back to running and exercise. More commonly in the older patient population, when we're dealing with bone-on-bone arthritis, there are 2 main surgeries that we talk about. We talk about an ankle fusion, which is also called an ankle arthrodesis, and we talk about an ankle replacement, or an ankle arthroplasty. Both are viable options. For decades, an ankle fusion was the surgery that was done. That's basically where you take the talus and you take the tibia and you make it one bone. So the joint is gone. It's one single bone. That eliminates all the motion, but it also helps eliminate all the pain.
Right.
Whereas an ankle replacement is like a knee replacement and a hip replacement. You make cuts in the bone, you remove away all the bony debris in the joint that's broken down, you replace it with metal components, and then there's a high-density polyethylene plastic liner in between that now functions as the hinge for that joint.
Right. So with the younger people, it's probably a little bit easier than those who are over 40, I would say, right, with the surgeries.
Yeah, they tend to recover a little bit quicker. The options are limited in a sense. If you have bone-on-bone arthritis in your 20s, then it's very tough to put an ankle replacement in because those are more so designed for walking, for low-impact activity. They're not designed for pivoting or basketball,
Jumping
soccer,
or
jumping,
yeah.
mountain climbing. You know, these kind of activities, they're not really designed for that. Some people still get back to it, but more so the strategy in a younger person would be to try and preserve that joint for as many miles as we can.
Right. So with the ankle replacement, the mobility is going to be closer to what you had.
Correct.
Than having the infusion, which is, kind of last resort, and,
Yeah.
At least you can
Right.
walk.
So when we do an ankle fusion, the emotion's completely obliterated. There's 0 at the ankle joint. And that's the goal, right? There's no motion, there's no pain. But with ankle replacement, the motion's preserved. And it's gotten much, much better over the years in the sense that when we used to think about an ankle fusion and we compared that to an ankle replacement, the studies were showing, they have similar patient satisfaction, they have similar pain after surgery, they have similar function after surgery, but the ankle replacement was higher risk because it requires more dissection, it requires more cutting of the bone. We have to do a big open kind of approach to that joint to put the ankle replacement in. And so people ask why, right? Why take the higher risk of infection, higher risk of injury to blood vessels? Right. And more recently, the literature has been showing that patients have higher patient satisfaction. They have more motion at their ankle joint. And things like exercising, driving, and even their day-to-day gait and their walking is closer to normal. And so the patient satisfaction is actually higher with modern implants.
And not to go back to that old song about the knee bone connected to the hip bone, the thing is that people don't realize that when you have that arthritis in that ankle, okay, so now your body is shifting. It's taking more muscles to walk.
Yes.
It's taking more of a strain on your tendons.
Yes.
Okay, and a lot of people too, that with the feet problems come the back problems.
Yes.
Like hand in hand with each other because
right.
you're not walking right, you're shifting your weight.
Yes.
Your back is used to being this one little way that it's been all your life, and now all of a sudden pinched nerves in the back, all these other things, and arthritis also can
absolutely
affect the back too?
Absolutely. Deconditioning is huge in this patient population. And so when you have arthritis in your foot, you have arthritis in your ankle, you tend to decondition quickly because it's so painful to walk, and you tend not to. It's hard to compensate. It's hard to cope because when you walk a mile, there's 27 tons of force that goes through your foot.
Right.
It's a lot. It's a tremendous amount of force. It's very easy to get to a point where you can only walk a few feet and you're limping. And as you limp, one side compensates, your back, your hip, your knee, they all compensate. And as the alignment changes, the alignment in your knee can change and the alignment in your hip can change. As a result, it can affect all the joints proximally. We try our best to correct that when we're doing surgery, but apart from going in and actually changing something mechanically, it's very hard to treat that without any kind of intervention.
Right. It's not exactly like going in there and changing a spark plug or anything like that.
Right.
But then again, this is life-altering surgery because you couldn't walk, you can't get around,
Absolutely.
and especially here on the island, you have to be able to get around.
Yeah.
It's not like the city where the local store is downstairs or something like that. You have to be able to move around. So
Absolutely.
the mobility of the patients is almost 100% restored, right?
That's right. Yeah, and it's a high-risk surgery. There's no doubt, but the goal is to do the right surgery in the right patient at the right time.
Right.
And realistically, if we think about the average person, they don't have surgery every day. This is a once-in-a-lifetime kind of problem.
Right.
And so it's important for us to really prepare the patient, to educate them, make sure we're making the right decision. Trendy things are trendy, and everybody wants the fanciest new thing. Sometimes it's not always the right thing. So it's important that if we're going to make this once-in-a-lifetime commitment, that we're doing the right thing for the patient, we're doing the right surgery, and that we do it right the first time so that the outcomes are optimized as much as possible.
So a patient comes into you they have ankle problems and stuff like that. So in your toolbox, you're going to do an evaluation of it.
Absolutely.
So you can pick which treatment would be best, say infusion or the thing with the what do they call it? With they inject it to the cartilage to keep it.
Yeah,
I forgot
absolutely.
the name of that.
Yeah, I mean, early before there's much arthritis, you can start doing infusion type treatment options. There are several injection treatment options, and lots of strides have been made in that realm of orthopedics, where they're trying to preserve the cartilage, prevent you from getting to the point where you need surgery or need a replacement. Many of these interventions buy you time, and it's important. It's not just that we're just waiting for that inevitable replacement.
Right.
But those are the years of your life that where you're more active, you have more energy, you have more kind of resources available to you. You might want to travel the world, you might want to cycle, you might want to mountain climb. All those things are a very personal goal, and so it's important for us to just try and give you all the tools in your tool belt to be able to achieve your goals. But if and when you ever come to that point where the pain's no longer tolerable, we've tried everything else, then we start looking at surgical options. And surgery is high risk, but it's high reward. It can give you your life back.
Right, and that's the whole thing. Is a life not walking worth it to you? And the pros and cons. Each person is different, and when you guys bring a patient in for an eval, you find out what their background is. Let's say they're a plumber or an electrician, or maybe the person's a dancer or something like that. I know you must see many of those injuries.
Absolutely.
Gymnasts, stuff like that. These are people that are constantly putting that ankle under that tremendous force.
Absolutely.
And a lot of people don't realize that, if you really look at the ankle, look at your own ankle, this little ball here, and then just picture all that tons of force that you were saying on this little thing.
Yep.
Yep.
Even
a ball bearing might crack.
Yeah.
So.
And even you might just have a small area of arthritis. Well, that's still a lot of force going through that one small area. There's a reason for it to be sore.
Right. Now, the next thing is the person comes in, they've had the surgery now, okay, they're feeling better. How is the recovery working with this?
Yeah, the recovery is slightly faster with ankle replacement compared to an ankle fusion. An ankle replacement, typically you will be in a cast for about 2 weeks. You are non-weight bearing for about 2 to 4 weeks, and then you'll transition to a pneumatic boot, a walking boot shortly thereafter. Normally we try to get people walking in about 2 to 4 weeks. And physical therapy will start somewhere around that time, the 4 to 6 week mark. I would say most of the surgical pain will abate. Most of it will be gone by 6 weeks. And the goal is to have you up and moving and walking on something that feels like a normal ankle by 3 months.
Right. And when you say non-weight, that means
That means
no,
you're not putting any weight on it.
you're on crutches or something, no
Crutches
weight,
usually, yeah.
zero weight on the joint.
Now the fusion, you're in a cast for 6 weeks at the bare minimum, because we're trying to get that bone to heal to another bone where there used to be a joint. And so
Right.
typically you're in a cast for a longer period of time. You're non-weight bearing for a longer period of time, and then the physical therapy starts after. Remember, we're not shooting for motion in that joint anymore,
Right.
so it's not like you're doing tons of range of motion exercises and doing tons of strengthening. The goal of PT at that stage would be to kind of learn how to walk with an ankle that's fused, how to retrain your brain a little bit and retrain yourself to exist in the environment around you. Your driving is now different. Your walking
Right.
is different. You try to get on a bike, it's going to feel different.
Right. And, having the ankle with the infusion and the replacement, as far as the benefits are concerned, there's the only benefit you're really getting is that you might be able to walk. With the replacement, you're definitely going to be able to do a lot more than that.
It's looking like more and more that the replacement will have better patient satisfaction because you preserve motion, right? The ankle's supposed to move. There's less stress seen by the neighboring joints. It's a similar concept in the spine. As you fuse spine segments, the neighboring segments now see more force. The same
Right.
thing is true in the foot. If you fuse the ankle joint, the joint underneath the ankle and the rest of the joints in your foot now see several tons more force. And as a result, they start to break down as the years go by. Whereas with an ankle replacement, you don't see that necessarily, and
Right.
the risk of having pain in those neighboring joints is much, much less.
Right. Because the way, like we were just describing before, with that weight of force shifting and going around
Right.
and affecting the muscles, the tendons, and everything. And it's really hard because, like you said, if sitting down, okay, you might be okay. But if you have to get up, go to the bathroom, have to do this, make your lunch, make your dinner, stuff like that, it can really be debilitating. That
Right.
people,
Right.
totally immobility.
And the goal is to keep you mobile and keep your independence.
Right.
It's people are very reluctant because surgery is scary, but from our perspective, we're addressing the mechanical problem. Once the joint is addressed, then we have to get you moving. All the scar tissue that forms after surgery has to be broken down, and then once the scar tissue is broken down, the muscles have to be built back up. So the whole process is really about progressing in that direction. We don't expect you to be magically better in 6 weeks, but it's a spectrum. And so as time goes on and you build your muscles back up, you'll notice that you're walking better. You'll notice that
Right.
it's easier to get to the kitchen than go around the block.
Not going to be
and then-
running the quarter mile after the first month, right? So, but also with the surgery, who are the best candidates for this surgery?
Right. So
Now, age group, everything.
yeah. So for ankle replacement and ankle fusion, the replacements tend to do better in patients that are a little bit older, that tend to want to use it mainly for walking, and that don't have any underlying medical comorbidities. It's harder in patients with diabetes. It's harder in patients with peripheral vascular disease, just because the tissues supplying that area are not as robust, and so they don't
Right.
respond well to us doing dissections and cuts in the bone, as well as putting in a replacement and then rehabbing it after. It doesn't respond well. Whereas those patients are good candidates for an ankle fusion, right? They're high risk for surgery in general, but if we do an ankle fusion, there's a less risk of things like infection. The dissection's much less involved, and the rate of successful outcome is relatively high. Whereas if they were to have an ankle replacement, they would have a high risk of infection, wound breakdown. They might have a high risk of fracture due to bone quality. All these things need to be factored in, and it also depends on how severe the deformity is. Many patients who come in with bad ankle arthritis, their ankle might be 30 degrees facing outward or inward, and the more severe deformities will often push us to do a fusion as opposed to a replacement type surgery.
Now, one of the terms that just for the people, that when you guys refer to gait, you're not talking about like a fencer in the yard and stuff like
No.
that. Gait is the positive or negative, the way you walk. Your feet could
It's
be
the way
like
you walk.
this, so your feet could be...
Yeah,
Right.
gait is basically, it's a study of the way you walk. It studies all the cycle of your gait, when your foot strikes the ground, when it's flat to the ground, and when you toe off, and how long it's in the air. There's various metrics that they use to study that. And so when we talk about someone's gait, it's how they walk. When they talk about a limp, that limp can be due to very many reasons, but typically in the setting of an ankle arthritis, it's an antalgic gait, meaning your ankle's painful, so you spend less time on that side. And that's what creates a limp. is a painful ankle. You spend less time weight bearing on that painful ankle and spend more time on the other side. And it becomes asymmetrical, and that leads to all the problems that we talked about. If you have a replacement, that gait becomes more normal and symmetrical and more time moving and walking on that side. Whereas in a fusion, your limp might be partially restored because you no longer have any pain, but you also don't have any motion on that side.
Right. And again, also getting back to this, when the patient comes into you, you guys measure the gait, you have them walk in front of you, right? You have all the more tools in your toolbox to check those things, because after years and years of doing this, you kind of know, even when the patient first walks up to you to say, "Hi doc, how's it going?" You can kind of see.
We have eyes on them when they're walking down the hallway. Before you even shake their hand, you kind of have an idea of what's going on.
Right.
Yeah.
Because it's very rough to make the determination, because some people may watch this program and say, well, I'm a candidate for that, but I have diabetes or I have this. There are other alternatives for you that you can have besides just this.
Right.
But if you're basically the 50 plus crowd, I would say, and you've had something, devastating accidents, that's another thing where the ankle is like kind of crushed.
Absolutely.
This surgery can be done to save, right?
Absolutely. And nowadays, when we get into the more complex surgeries, people have had fusions in their 30s and 40s, and over time, as the other joints start to break down, as the tibia bone starts to see more stress, then lots of various pain factors get exacerbated. So in those patients, sometimes we consider taking down the fusion, meaning we unfuse the bone and we put in an ankle replacement. And that's also an option for people. So there's various techniques we have to help people with their pain. It's a calculated decision, right? It's not a yes or a no, but it's like we consider these risk factors, we understand the risk involved, and if your pain's bad enough then that you're willing to undertake those risks, then we do that surgery for you.
And that's the next part of doing the assessment, is that you sit down with the patient and you discuss all the options that are available for them, and what's good about it, what's bad about it, because it's just like every medication's got a side effect to it.
Right.
So that helps you make an evaluation with the patient, what's the best proper care.
Yep.
Now the other thing is, you've had the ankle replacement. Now, is it like a tire? How many 1,000-mile guarantee do you guys give on it?
Yeah, I mean, you made a good analogy, because it's kind of like a tire. The more you drive, the quicker the tires wear down. If you get an ankle replacement in your 50s, you have a lot of miles to walk, and so those tires might wear down to the point where you need to have them changed out. Right. But modern-day implants that have come out in the last 5-10 years, they tend to last 20-plus years if done in an older patient population. The last study I read stated that after 10 years, 90% of patients are still happy. There's not so much wear that we need to go in and change things. But as soon as you kind of get around that 20-year mark or a little bit longer, that's when that polyethylene, that plastic component, starts to really wear down, and we start thinking about changing that out if you're having pain.
Oh, so you can go in for a retread then, actually.
You can change those tires out. Yeah.
Exactly. So now, with the material that's in there, like some people are saying, it's like Teflon or something like that, but it's a lot more durable. This is like stuff that you could beat with a hammer, and you're not even going to
It's ultra high molecular weight polyethylene. It's very resistant to shear forces. When they first designed it, they said that you can make an ice ring out of it, and you could skate on top of it, and it would barely be touched. So it's very durable stuff.
So if you had the ankle replacement and going down the road, let's say you had it in your 40s and you're now 60 and you're starting to notice.
Yeah.
You guys can actually go in there and replace that instead of replacing the whole ankle, though, right?
That's right. Yeah. Many people will simply just need us to go in, wash out all the particles from the plastic breaking down, and change the polyethylene out. And many patients will be happy with that. Their pain will subside, and it's a much quicker surgery than revising everything, right? That being said, if it's been 20 years, sometimes patients have cysts. Sometimes they have one of the ligaments will be torn or stretched out. So it may be more involved than simply changing the tires, but many patients will be candidates for a simple exchange of that polyethylene component and closing everything up.
Good for another 50,000-mile checkup, and you're all set to go.
You got
it. It's just really incredible how medicine, just over the past 5 years, has come, with the use of technology and everything like that. Now, also, people, one of the biggest things that they do is they get afraid. And knowledge is power. So I'm pretty sure that you sit down with all your patients, explain everything to them, you know, pros, cons, and there's no need to, you know, fear and stuff like that, because fear seems to be, you know, number one, you know, it's like, am I going to still have a leg left when I'm done here? You know, should I make out a will before my surgery? You know, stuff like that.
Yeah, I mean, you know, it's scary stuff, right? You go under an anesthetic, you put your life in someone else's hand, and someone puts you to sleep, you wake up, and someone's made an incision, and you have a new joint in there. It's going to be painful. But we do our best to tamper all the concerns. And we do a lot of these kinds of surgeries, so we get good at it. We have several staff in our office that check in with our patients every day, especially after surgery. We get very good at knowing what pain medications work for which people and how we can best treat the pain. There's no overstating how helpful it is to elevate it and ice it, to keep the weight off of it when it needs to be off, and elevate it when it gets swollen. Many of the strategies that are that we utilize now, they're simple, but they work, right? And I tell all my patients the same thing. It's very hard to have zero pain. We're trying to take the edge off. The worst days are the first 2 days. And after the first day after surgery, you probably hate my guts. You're probably cursing my name. And 2 weeks after surgery, a lot of the pain's gone and you're feeling a little bit better. We take the sutures out. We have a look at the incision. We put you in a cast, or we put you in a boot. And then at 6 weeks, you're pretty happy with your decision. So
then they want to name a child after you.
Yeah.
So, but that's one of the great things about Complete Orthopedics. You were one of the top surgery places here on the island, and you know, one call does it all. You guys handle all sorts of joints and stuff like that. But you know, as far as recovery, is it better to spend 5 weeks of your life trying to get better, or the rest of your lifetime trying to walk? So,
yeah, I mean, I think it's a good investment, right? It's an investment of your time, it's an investment of your energy, and it's very stressful. But as people start to put on weight, as the joint becomes more arthritic, there's no solution in sight, right? Or do you want to go down the spiral of having a chronic pain and chronic condition where you start to decondition because you don't want to move anymore, or you do want to make a proactive change, right? It boils down, it's a personal decision, but it boils down to investing the time, investing the effort, so that a year from now, you're happy.
So you got your tune-up, your retread, you're all set to hit the open road,
That's right? That's right.
Yeah, it's rough for people, especially, you know, with, you know, the fear, the technology, everything that's coming out. Some people are like, oh, it's too fast, and God knows the insurance companies, you know, they still haven't approved aspirin. So, you know, it's like it's a new treatment, you know. I mean, but it's out there.
It's out there.
It's out there. It's already helped hundreds of people,
Yep.
and it could possibly help other people if you need that type of surgery.
Absolutely. And I think what's exciting is we're at that point now where the paradigm is shifting. When hips and knee replacements first came out, they were horrible, right? They failed, they broke people's bones, they created cysts, they loosened, they pulled out, and they were horrible. And then now, cut to 40, 50 years later, and they're heralded as some of the most successful surgeries in the world. And so right now, I think the total ankle is making that shift. It's in that paradigm where the tipping point is behind us, and really we've found implants that are working very well. 90% of patients are reporting satisfaction, and we're in that exciting period where, hey, this could really change the way people experience their ankle pain.
I wanted to thank you for coming on the show and letting us know about this fantastic new surgery that's out there and it's available to people.
Absolutely.
And I look forward to having you back on again, maybe if we have some viewer questions and stuff like that.
For sure.
A couple of people who are just phoning in because they can't walk around. So
absolutely. Happy to, yes.
Okay, thanks a lot. I'm Larry Mike Arenda. Until next time, we'll see you right back here on the Excelsior Forum. Take care.